Hello, everyone, and welcome to our webinar, Automation, Virtualization, and the Age of COVID, how today's practices are streamlining revenue cycle management. Today, we have Matt Seefeld, one of the industry's top experts on all things automation and revenue cycle management. I'm Ashley Deitch, Vice President of Marketing for medlevolve, and I just have a few quick instructions before I hand it over to Matt. All of you are on mute right now to prevent disruptions during the presentation, but we do encourage questions. You should see a control panel to the right of your screen. If you don't see it, you can access it from a tab at the top of your screen. Please submit your questions at any time throughout the presentation, and Matt will address them at the end. This webinar is being recorded, and I will send a follow-up email to everyone who is registered with a link to access the video. All right, Matt, let's get into it.
Thanks, Ashley. So some of you I've probably spoken with. I've got my entire career has been in revenue cycle management. Started my career as a consultant, flying around the country trying to fix complex rev cycle problems front to middle and back. Really learned early in my career the importance of data and intelligence, as well as workflow automation, holding people accountable for the work they say they're doing. So that's really a big part of what we'll talk about today. Here at medlevolve, I've got a few hats. I oversee all of our business development, all of our RCM operations, as well as our workflow and analytics business units. Sit on the board of some healthcare tech companies, and I founded a virtual community for those suffering from addiction. So if anyone's out there that knows of people that could use a little help right now, check out my lifelink on the app stores. So when we're talking about solutions for the new normal, I feel like new normal keeps changing every day, especially with the pandemic that doesn't seem to want to subside. Hiring, is a big thing we'll talk about. People not wanting to work, people want more money. Companies like Amazon providing major incentives for folks that are hard for us to deliver in healthcare to match. Those of you who have heard me before, key performance indicators, I always have to talk about that because I'm still amazed this day and age why people spend so much time trying to find out whether they have a problem, and that intelligence doesn't just come to you in seconds. And then, of course, the patient revenue with deductible season right around the corner, talk a little bit about automation and what you should be doing, and many of you already are likely doing to make sure that you're protecting your receivable. So, I've spoken at a couple conferences recently, and I could see people in the audience, so I would ask questions. How many people like hiring RCM folks? How many people are having trouble hiring RCM folks? Half our business here at medlevolve is revenue cycle management services. So we do everything from the charge entry coding all the way through the payment and claim adjudication to zero balance. And we've got lots of reps that are outstanding right now. I think one of the things that we learned early on was the importance of allowing folks to work remotely and virtual. When the pandemic hit us, as it did the whole world, and really end of March, early April of 2020, we had to send everyone home immediately. And luckily, we had built technology that allowed us to do that and measure the production and effectiveness of staff that are no longer in the office. So a little bit about us. I took over revenue cycle in April of 2019. Our margin was gone. It was in the red, and our service was not where it needed to be. And I started to ask questions to the management team that should have been affirmatives in seconds, and they weren't. Looking at basic stuff like how many claims are out there, what's been worked, what hasn't been worked, which client has issues, is it issues on the front office revenue cycle, or is it the back office and us, right? All these things that we should know in seconds, we didn't have. Then I got into the FTEs, the human capital side, right? Okay, so the people working, for example, insurance AR, how do they get their work? How do you know what they're doing? What's the status of the AR they're working? What actions are they taking based on the status of the AR they're following up on? Again, I've been doing this for 2 decades, and yet these practice management systems can't do that, right? And they won't do that, right? Practice management companies are focused on the clinical side, right? Making sure that their EMR, most of them have an EMR, is adequate for the physicians, and they're now focused a lot on the patient engagement. They're focused a lot on the consumer side of the business, which they should be, but what gets left behind is it's the technology that allows you to automate the basic revenue functions, revenue cycle functions, And it's the intelligence and the transparency tools that tell you whether you have a problem or not in seconds. And that's a limitation I have literally seen over 21 years, and I don't expect that to change. And we had that here at medlevolve, and what we did about that over the last 2 years is we built a lot of technology that's focused on holding people accountable, as well as telling the story, a revenue cycle story in seconds. I'll get into more of that. So let's talk about virtual communication. I always ask the audience, when somebody needs somebody else in the revenue cycle to do something, how do you tell them that, right? In the olden days, prior to COVID, it could have been face-to-face, but if you're in my world, there is no face-to-face anymore, right? So it could be a phone call, could be an email, could be a post-it note, right? All of those things were ways that which we could have communicated, but no longer are relevant today. And when I say relevant, especially when you look at things like emails or phone calls, is there's no way to hold accountability of the person that you're asking to do work. Like, did they get it complete? How many tasks are outstanding to get this claim paid, right? These are, again, basic questions that we need to solve here at medlevolve. And so when you look at a virtual workforce, you have to be able to assign not just claims and schedule appointments and those things. You've got to be able to assign all of the tasks that are around, because as I don't know about your revenue cycles, but for me, I can have 3 or 4 people touch a claim before we get it paid the way it's supposed to be paid on time, right? And I need to know how many touches are occurring to see where I can improve efficiency upstream of that. Messaging is a big thing too, instant messages and logs, right? We have that now as mainstream society. Why not have that in a task list engine? So if I'm on the phone with, say a payer and I need Ashley to do something, she's online, let me quickly generate that task and see what her response is. So speed at which you get work done is important too, reduces your days in AR. So just Deloitte, I used to work for Deloitte back in the day, so I was happy to see a study out there that talks about employees and how they're working remotely and what access to tools they have. And you can see helping task management and productivity is very low there, as in it's not, when you look at healthcare, that has to be improved. And so what that tells me is that in healthcare, as a general statement, we're not very automated in terms of how we ask people to do the things that we need them to do to get paid, right? So one of the things that I always take into consideration when I'm looking at any sort of workflow automation suite is how many clicks does it take to get my job done, right? You think of the iPhone now, right? If we're sitting there looking at our phone, I think somebody just said that the new release is going to have the search on the bottom so that you can just do everything with your thumb, which I'm sure that hand doctors will be excited about, because you probably all end up with thumb carpal tunnel and have to get some form of surgery or injection there. But the bottom line is, one thing Apple figured out is it's easy, right? I can send you a device and it's 2 clicks. You don't even have to read the quick start guide, right? You got to start looking at your PM and the tools you have either in the PM or around the PM and ask those same questions. How efficient can you be when you're asking people to do their work, right? The other big thing on tasks for us is being able to classify the departments along revenue cycle that are holding up the tasks, right? So if I'm looking at this view and I can say I got 445 open tasks right now that are assigned to claims, I can see the cash value, the estimated liquidity on those claims in the far right there, about $123,000. So it's a material amount of money that's being hung up in tasks. I now know charge entry, coding, payment posting are probably the top 3 departments that I would start working with to say, hey, what's going on here? Charge coding, your average response time is 9 days. Your average age of task is 19 days. You've got a task that's sitting out there that's 70 days old. What's up with that? You've got 60 that aren't even read yet. When your staff recognizes that you have transparency into this level of detail, behaviors do change. They either self-select and go find another job somewhere, which is okay. They don't want to be on the bus and drive results for the practice. That's okay. Or they rise up. And then we'll talk a little bit later about what we've done here at medlevolve in terms of an incentive-based revenue cycle for folks who consistently deliver the outcomes that we're looking for. So how to get started, right? I think I've already touched on this a little bit, is that it's about how quickly can your FTEs in revenue cycle get their job done, right? So if I'm a AR representative and I'm calling on a insurance plan, can I actually correct a claim right then and there and refile it, right? If I'm a self-pay collector and I'm calling on a patient claim and the patient says, actually, I have insurance, it's Blue Cross, right there on one screen, can I run eligibility while the patient's on the phone and say, actually, you don't have Blue Cross? Oh yeah, no, sorry, I changed to Aetna. So what is the tools that your folks have in real time to be able to understand the work that they have to do and be efficient with it? You know, life is about being more efficient at the unit of work that we do. So for example, if you have an AR rep who's working 50 a day and you can streamline the way they work to make them more effective, maybe it's 70 a day, right? And so, or you can reduce your labor expense, which we'll get to here in a little bit as well, which is a big initiative right now in healthcare, especially as margins are being put under pressure with the reduction in reimbursement from insurance companies, as well as the increase in the high deductible plans. Claim statuses too, you know, making sure that the clearinghouse you're using is able to deliver those claim statuses, making sure you can deliver the remit straight to the collector so they're not having to log into a different system. Everything needs to be right then and there. If they have to update a diagnosis code, change demographics, any of that needs to be done in as few screens and as few as clicks as possible, okay? So disparate systems call for data warehouse. So I was at Ortho Forum and a couple larger conferences this year, and data warehousing has really become a hot topic. I'm amazed how many clients that we work with who have had their data held hostage by their vendors. It's your data. It's not okay. You've earned the right, and you have the right to access your information and do what you want with your information, which could include putting a workflow automation technology on top of a data warehouse or putting analytics technology on top of a data warehouse. Many of you on this call probably have seen the value in that. But if you're out there right now and you're waiting on data, you don't have the information available, and you know you're being charged a lot for custom reports and things like that, you've got to look at what you can do in building out your own. Okay, and that's just something that's going to become more and more imperative. You're also at some point going to want to bring in the clinical data, right? You know, starting to look at the financial data and the clinical data together to start to really look at outcomes. So definitely something that I will impress upon you throughout this webinar today. So this is my consulting hat, right? I'm amazed in the sales process when I'm selling something to a prospect where there's a large ROI, but they believe that just buying the technology will get the result. That's not true. Any vendor that says, I've got the tech for you and this is what you're going to get, is frankly lying to you because they don't know, right? When people ask me what I'm selling results. Now, how I get those results is through understanding the gaps in your revenue cycle today and whether I fill them or not. You know, many times when I fill the gaps with technology and in some cases services, I'm actually helping to redesign the revenue cycle to align with our technology to get the best outcome. I'm still amazed at how many clients out there are set in their ways that, well, this is how we've always worked AR. Okay, did that work 10 years ago? Maybe. Is it working for now? No, it's not. So you've got to start realizing that just by buying tech does nothing for you. Looking at your people and the processes they use and how they will align those new processes with the technology, that's what drives results, okay? And so really start to assess all areas of your revenue cycle before you start thinking about what do I need. The conferences are great. The vendors have really cool gadgets at their desk, but again, you've got to challenge each of these vendors you're looking at to make sure it's going to be the best fiduciary decision for the practice and get the outcome that aligns with your business objective. So then design, right? So design the way in which you want people to work. Now, where workflow automation comes in is there's no more democracy. Like in my world, it's a dictatorship in a positive term, right? You come in the morning, you log in, and the first claim that pops up in front of you as an AR rep is the one I expect you. And you're going to work, you know, in a way that I expect you to work. And that allows me to measure your outcomes, you know, your effectiveness, which we'll get to here shortly. So make sure that as you're designing your workflow process across all areas of revenue cycle. And this could be scheduling, you could be looking at your pre-reg process and what tools you could do to prevent no authorization, COB eligibility denials, reducing your bad debt expense by being more proactive at collecting deposits from your patients and prior due balances before seeing again. There's all kinds of tactics that you could look at across the entire revenue cycle where a technology solution may fill the area, but you've got to also look at how you're going to have to make changes to your process. You know, and I get frustrated at times when I hear that, yeah, but Dr. So-and-so, he likes it this way, or she likes it this way. That's okay, but you told me your objective is you want to improve margin, correct? Yes, I do. Well, then this is what I'm telling you need to do. Now, if that objective has changed and the objective is to make sure Dr. So-and-so is happy, that's fine too. Then stay in the way that you're doing things there. That's okay. So getting started, you know, once you've determined what type of automation you have access to today, or you plan to build out, or you plan to buy and integrate, right? However that is, then you've got to make sure that that vendor you're working with brings the expertise to the table. You know, our development is not done in a vacuum. We don't actually develop anything nowadays that's not going to help make our RCM efficiency maximize as well as our clients maximize, right? So we have subject matter expertise infused into everything we do, right? It's not just I've come up with a really cool technology, it's in my head, I know it's going to work, here, try it. Well, is it going to work? Has it worked? Like, do you understand my revenue cycle problems before you start pitching me, right? And so it's got to be a consultative relationship, at least in the early days. And so we stay connected with our clients for months and honestly, in some cases, years, because it's our best interest to get results, because that's what gets us out on stage with them at conferences, it gets us referrals, and in this day and age, when you're selling to healthcare providers, it's a very commoditized, crowded space, so any differentiator helps. So what are some of the benefits, right? We all talk about getting claims out clean, right? From the moment that charge is entered, does it actually go out the door clean? Does it get paid exactly what it's supposed to be paid on time, right? If not, why? Are there ways that we can improve that? Prioritization is a big thing too, right? It helps you prioritize the areas of revenue cycle. So if your net collection rate is 85% and your labor cost is high, then you know those are two big objectives, right? You got to have a leaner workforce that actually delivers more effective results, right? Leaner workforce reduces your labor costs, better results, increases your net collection rate. Everybody's happy, okay? Visibility too, right? You have to have more visibility into every aspect of revenue cycle, right? And this isn't wait until the end of the month stuff. This is fingertips. This is real-time information that allows you to make real-time decisions, right? Every other industry other than healthcare seems to have figured this out, you know, but healthcare on the finance side seems to still think that, you know, running pivot tables and waiting for the end of the month and taking 2 months to close the month and all that stuff is a good way to run a business, and it's not. Well, you can't run it. I mean, again, 5 years ago, 10 years ago, 20 years ago, okay. But now, especially with what we've learned with COVID and all the cyclical things that have gone on, it's not going to be a way you can manage this going forward, which is, again, it's a lot of times we're seeing our physicians sell to the hospitals, they're selling to private equity firms because they're just out. They're like, hey, you know, I'm just going to sell it, and you know, I'm going to let somebody else deal with it. Okay, and that's, you know, like if you're an independent physician group and you want to stay independent, you can, right? You can, but you got to have these things that I'm talking about in order to do so. Visibility into the RCM folks, right? A lot of times when I'm out visiting with clients, you know, and say, hey, you know, on your current PM or your prior PM, how did you measure staff production? A lot of times they're like, well, we really couldn't, you know, and then it's like, well, so-and-so touched this many claims. And I'm like, well, touches is one thing, but were they effective at those touches? That's a totally different concept. So when I'm meeting with our RCM team internally, I say, like, I'm actually less concerned about how productive you are as to how effective you are, okay? Making sure workloads are balanced. I can't tell you how many times we'll take our workflow management system live based on the way that they're doing their business office today, and Sally's got 4,000 claims and Bob has 200. Okay, that's not going to work, right? So making sure your workloads are balanced, whether it's charge entry, coding, payment posting, pre-registration, AR management, everything in between. Employee satisfaction. So this is an interesting one. I'm sure there's been centuries of psychologists that have tried to prove me wrong here, possibly. But here's my take on what I've seen in my experience is that when you actually put major structure around the way your people work, it's like the stages of grief, right? The first week to 2 weeks to even month or more is this doesn't work, it doesn't work for me, it's not right, I don't like it. But then you start to see the results, right? And usually the results are the increase in cash flow, right? The improvement in net collection rate, maybe a little reduction in labor, and now all of a sudden it's like, whoa, this is working. So the ships have been burned, right? We're not going to go back. You know, we're here to stay. And people start to get to acceptance. And what's cool about acceptance is that there's folks that will rise up and realize that, hey, you know, I like what I do and I'm proud in what I do and I'm proud to be recognized for the work that I do. And so if you think about the way, I'll use a real example. When we went live with workflow, this was 2 years ago in its beta form, you know, there was some bugs in this, like any software. And so our software platform went down for, it was probably 20 minutes. And we had representatives that were so used to having their work delivered to them, so they didn't have to stress about where they were going to find their work, that they were, a couple of them were in tears asking when the system was going to be back up. And that just kind of resonates with me, that as much as our perception is people don't want to be held accountable for the work they're doing, they want to work on their own, there's actually an ease that comes when people recognize that, hey, this is what I have to do, right? And so but again, you've got to be willing to get through the stages of grief in order to get there. And I think having an incentive-based revenue cycle, which has good financial incentives in there as well for performers, is going to be really critical. So let's talk a little bit about measures, right? Most of my meetings on the business development side, when I ask what are your objectives, it's usually around reducing labor dependence, because it's hard to find people right now. People are leaving, people want more money. I don't know how effective my people are. Or most of the time it's an and. Net collection, right? So I bill $1, I expect 96 cents back. I'm getting 85 cents. Why am I not? Where's that 11 cents? What is it? Because there's something I could have done to get it, right? And so there's really those two pieces. Gross charges mean nothing to me, but at the end of the day, your labor cost and your payments, NCR, is what drives your margin, right? And so we're seeing margins go down pretty quickly for all of our businesses, us included, because of the reimbursement changes between insurance and now the shift in patient, and then also having ineffective workflows for our staff. So we end up having to throw bodies at a problem versus actually having automation to make sure that the work that's delivered to each person needs work done. And there's a big difference there, right? I need to carve out the nonsense as quickly as possible so that my folks are working things that require action that will actually move the ball down the field towards the goal line. So some of the macro level operating measures that I like to look at, you know, and again, this should be real time. You should be able to log into something. In our case, we use Microsoft Power BI to do this, but look, billing whip, right? Charges that have been entered that are hung up in an edit, whether it's native in your practice management system or it's in your EDI vendor, okay? As well as rejects from insurance companies. Unposted remits, right? If you have a posting problem, as in maybe not enough staff, you know, you need to understand, especially as you approach month end, how many ERAs are actually out there that haven't been processed yet. So for us, you know, we have had the cyclical changes in our payment posting. We brought on a lot of clients. It's upped our payments coming in, which is a good thing. However, you know, trying to keep staffing. And so I look at that every single day to know, hey, if I have more than a day or a day and a half in unposted remits on average compared to what I post on a good day, I have to start asking questions. Comparing visit volume charges month versus last. I know it probably wasn't as relevant pre-COVID, but it is now, right? So if I'm in halfway, right now I'm at the end of September, and I'm only at 35, 40% of the charges that I put out last in August, that's a problem, right? Now I need to start looking at things like, well, when was the last charge entered? So surgical charge. Oh, geez, I've got an 8-day backlog in surgical charges, so that helps to explain it. Starting to understand how certain metrics create relationships together, right, tells the story really, really quickly, right? And so most of the time I can have a hypothesis and prove it quickly by looking at measures like this. Looking at things like unworked claims. When I go into a sales pitch, I always say, okay, how many open claims do you have in your AR for insurance? Most can't answer that. Then I say, okay, let's assume you could answer that. How many of those claims have been worked? Most can't answer that. I say, okay, for the ones that have been worked, how many haven't been worked in the last 60, 90 days? How many claims have been worked more than 5 times that have had no insurance payment? They just keep getting hit by staff. We're not making any progress, right? These are all things you need to have access to. And so that's a big point. And then of course, now looking too at canceled appointments, we just launched a recall service through our appointment reminders that allows us to actually go out and engage with canceled patients to say, hey, canceled your surgery, let's get you back on the books, right? And so with COVID and people shutting the ORs down and people worried about the variants, I'm sure you all are experiencing canceled by patients and also having to cancel some of your own as well. You've got to make sure those folks get back on the books. So intelligence in a single view. These are just some new views that I've been working on recently. You all may have views like this. If you don't, I encourage you to build these out. Definitely make sure it's real-time data. This isn't something that you want to look at every month, because some of the things that you'll see on a view like this may require action today. But being able to look at things like, are my charges trending upward or downward compared to the last 90-day average? What's my charge lag looking like? What's my insurance AR over 60 looking like? What are my days in AR looking like? What's my net collection rate looking like? How long does it take the insurance company to respond to me? How long does it take me to post a payment? How many claims are being worked by my collectors on average per week, right? And so you start to get into more measures that actually come into one single view, and it takes seconds to say, hey, these are the 5 things that I may be looking at. Maybe you're going to look at 3 or 4 financial locations, 2 or 3 doctors. If you're an RCM company, maybe you're looking at 4 or 5 clients this week to figure out what things you need to put in place and change to drive better results. Net collection rate is one of my favorites. I'm amazed at how most PMs can't actually get this data in real time. This is something that I like to look at because if I'm not collecting benchmark or close to benchmark, I need to know why. I also need to know what I'm still waiting on for insurance and what I'm still waiting on from patient. Okay, and so this is a really, really important view. I ask for this data when we're going into sales opportunities. I can rarely get good transactional information to even give them a reasonable calculation of an NCR, which is also, it's sad. It's sad finding, because you should be able to now look at a view like this, and I could say, I want to look at just Medicare. I want to look at Medicare for Dr. Smith. I want to look at just surgical Medicare for Dr. Smith, right? And this stuff should just update in real time in front of you. We don't have time to wait on information anymore. Information has to be given to us. It's like, imagine being in a battle zone and we're like, trying to get intel of where the enemy is, and it's like, hey, I'll get back to you in a couple of days. Well, that sucks. We got to dig in, right? It's like, no, they're right around the corner, go this way. Okay, we've got to start treating healthcare like that. I mean, we're doing it on the clinical side in many cases, but why not on the revenue cycle side? Why does that keep getting left behind? Claim statuses. A lot of times I'll ask clients, prior to using medlevolve, what's the status of your AR? What do you mean? Well, status. I mean, what is the status of the AR that your people are working? So again, when you think about how your teams are working receivable, for example, are they classifying their work in a structured way? And what do I mean by structured? Does that mean you've got a status code, right? You have activity, right? I called the pair. You got a status code. What did they tell you, right? Oh, denied for medical necessity. And you got an activity or an action code. What did you do about it? All those things need to be stored in a data warehouse, obviously, is where we do it, and then reportable, okay? Measuring productivity and monitoring, right? How are my posters doing month over month? What unit of work? Why is one poster 2 doing better than poster 4? Is there a training gap? Do I need to look at the complexity of the clients they're working on, right? Let the data tell a story that allows you to ask additional information. Load balancing, again, I talked about this briefly, but if you start looking at assigned claims based on your representatives, right? How much AR are they responsible for? How many of those claims have been worked? What percentage have been worked? I've got somebody with 5,000 claims who's only 7% through, that's a problem, right? Whereas if I have someone who's got 488 claims who's only 16% through, that's also a problem, right? So Now I got to go look at their productivity, right? I mean, you got the #1 person up there working 357 a week. He or she's hitting it hard, 69 a day, and still can't get through their stuff, right? So have all this at your fingertips that allows you to see it. Even unworked claim weeks, this was a new thing we came up with where I wanted to know based on daily production, in this case, weekly production, how many weeks would it take them to get through the backlog, assuming no other accounts hit their workloads? Again, it's more than 2, it's a problem. Now the question is, do you have a staffing issue? Maybe. Do you have a quality issue? Possibly. And so, you don't want to just throw labor and say, hey, I got to hire 10 more people to get this down. We got to look at the why are these claims not resolving as quickly as we expect them to. And then you get into effectiveness, right? When I work a claim, is it generating an insurance payment, for example, right? And so being able to look at your staff and say, how many actions are you taking per claim to get a good positive financial outcome, right? You've got one doing 1.9 and one doing 1.3. What's the 1.3 doing differently than the 1.9? Okay, so you identify training gaps, you identify performance gaps, you identify payer issues, right? And then of course, looking at when they're working. And this to the left metric is really, really key. And I can't tell you, I mean, sadly, we've run into quite a few examples in the last few weeks where people are clocking in and clocking out, but their work doesn't align with those hours. And we've actually had to let somebody go because of that. So if you're sending people home to work virtually, and even if you're staying within your own business office, four walls of your business office, staff need to know that you have immediate transparency into when they're working, whether it's a day a week or it's an hour a day, okay? When they have that intel and they know you have access to that information, behaviors change, okay? So looking at things like why AR changed, a lot of times, I'll ask a prospect, hey, if your AR drops by $1 million month over month, why is that? And usually they'll come up with some theories, but what really was it? Was it a big increase in charges, a lot of insurance money that came in? Did you do a bunch of contractual write-offs? Did you do a lot of non-contractual write-offs? If you did a bunch of non-contractual write-offs, what were they? And could there have been money associated with that, i.e. denials, right, i.e. bad debt? So again, it's more than just theories, right? We don't like to base decisions anymore on feelings. It's a bad place to live. We want to base decisions on facts, right? And that's a big thing here that we use as a motto here at medlevolve. And then of course the at-risk, and I kind of already walked through this example, but being able to really quickly assess based on your AR representative or your payer or your denials, that how much that AR has been worked, has been worked, how much stuff just keeps getting touched, and we're not getting anywhere with it. Can I start to send those claims to a supervisor or a team lead to look at, another set of eyes? So transparency into the work that your people are doing is key. And remember, to get the best data, you got to have better ways to capture structured data in your workflow systems. It's not just a spoke with Betty at Blue Cross. That's not actionable and that's not reportable. What activity did you do? What was the status? What action did you take? How far out did you push it before you would see it again, right? If you said you verified benefits and eligibility and you logged it, why did I get a verification of benefits eligibility denied? Right? All good questions. All trying to improve, guess what? Reducing labor dependence and improve net revenue. Forecasting, I'm going to kind of move through some slides here quickly. Look, forecasting, again, April of 2020, as an RCM vendor, half our business is technology, half is RCM vendor. Services, we lost like 80% of our revenue, right? As did our clients, because ORs got shut down, we all know that. Then we went in and started to build views that allowed us to understand the change in which charges were coming in, payments were coming in. We started looking at ways to value the AR better, to not off of a fee schedule, but off of reality. We then started to look at the timing of payments based on a lot of historical activity. So if I've got 214 million in outstanding AR, there's 27 or 61 million in cash value there, I can expect 14 million in the next 14 days, right? Another 7.2 million in the next 15 days, right? So timing of when we're going to collect has become a big thing for us as well as our clients. Predictability. Patient payment problem, right? So high deductible plans plus the mercurial nature of COVID and concerns about, will I get a job? Will I keep my job? Will I be able to pay my rent, my utilities, buy food for my family, right? All these things are not good when patients owe money for especially the elective surgical space, which is one of the areas we play in. So when you look at some stats there, I mean, we saw just internally in our RCM team a huge uptick in self-pay balances between just September and February of this year. September last year, February this year, 1.5 to over 4 million. I expect that to be even more enormous when we look at deductibles resetting here in January. Only average collections up front, 18 bucks. Not a lot of money, especially when you are a surgical specialty. 77% of the AR over 60 days, right? And sending statements, hoping that statements work, hoping people pay, right? Hope doesn't get us very far in life anymore, right? So we've got to put strategies in place to do our best to estimate the patient liability, collect a good estimate, make sure that we can collect prior balances for patients scheduled to come back in again. Don't keep seeing people for free. Mobile engagement, right? Using mobile text, email to facilitate payments, right? All of those things to reduce the dependence on paper, e-statements, and everything in between. So bottom line is reduce that bad debt, reduce those outsourcing, both early out self-pay fees as well as your collection agency fees by improving the way in which you manage your own self-pay side of the ledger. In some specialties out there, you're going to have a lot more cash dependence than others, right? And so the ones that have high cash dependence, like a lot of our ophthalmology groups that do a lot of cash pay things, man, it's imperative that you're collecting all that before you actually do the service. And avoiding preventable denials. 52% of our first pass denials here at medlevolve come from front office breakdowns, right? So it's nothing that I even control, yet I have to have the staff now to go work that AR and try to overturn that AR, right? And my rates have dropped significantly just through competition over the last 2 years. So I'm not getting the same percentage of collections that I used to. So now I'm being asked to do a lot more due to inefficiencies on the front office side for a lot less, as well as having to hire more people to make sure I can cover that. So basic things, right? You have a pre-reg department out there. If you're a small group, you probably have somebody dedicated to making sure that at least 2 or 3 days before you see someone that you verified their benefits for eligibility. If they coordination of benefits is a factor, make sure that that's verified. Demographic verification. I just ran an analysis of a large ortho group. 85% of the time they get a cell phone, 12% of the time they get an email. Look, folks, we as consumers are now used to being communicated to in a mobile fashion, whether we like it or not. Why is healthcare different, right? Get the mobile number, get the email. They can always opt out, but again, you got to have ways to engage with your patients beyond just a phone call or hope, right? Or waiting for them to show up to the clinic, which is the worst possible time to try to do these functions, right? Authorizations, all of these things need to be secured, and people have to warrant it in an automation tool that they did the work. And you have to have analytics that say on the back end that say, did you do it? You said you collected this money, but yet I don't see any patient payments coming through. You said you got the authorization, but I got to know opt and on, right? So again, you're starting to get the theme of my point here, right? Is we've got to hold people accountable for the work that you're paying them to do. So looking at financial clearance to me is about, it's like the old bed board days, right? Red, yellow, green, right? Who's the high risk, low risk, moderate risk, who gets admitted to the inpatient floors quickest, right? All of that. Why don't we have that with RevCycle? Why can't I log in the morning and look at my appointments as a physician or administrator and see who's red, yellow, and green and click on the red ones and see why? So we had to build this. We had to build this ourselves to then bring it as an option for our clients to use. Because you have to have this transparency. Again, if you go back to my original point, most of the business objectives when we're selling to the industry is I want to reduce my labor dependence and I want to improve my net revenue. This is the start, right? You get this right, you're going to be way more efficient, which is going to require a lot less people on the back end, which is reducing your labor, and you're going to collect more money on that dollar, which is going to improve your net revenue, right? So it goes hand in hand, but you can't just say it's an AR thing or it's a coding thing or it's a front office thing, right? You've got to look at your entire revenue cycle. I always have to bring this up too. For those of you who are still making phone calls to patients, you can stop. It's very expensive and it's not effective. 2 years ago, I came up with the 10-10 rule. So we have an auto dialer that we use. We don't use it as much anymore since mobile engagement is so much more effective. But back in the day when we were using a lot, you would call 100 patients, 10% of the time somebody would actually pick up the phone. And of that 10% is the person that you actually need to talk to about a bill, and 10% was willing to pay. The connect rate now for us has dropped to 1.9%. So do the math on that one. 1.9 people are going to pick up. How long would it take an FTE to call 100 people? How about 1,000 people? Too much. So again, use mobile means in which you can do that. Work with your current PM vendor, work with a partner, make sure that partner is integrated to your PM or integrated to a data warehouse so you have reporting out there. But again, these are things that need to be looked at. One other thing I'll just say on this slide is make sure you have flexibility in how you solicit payment, right? Do you have a good payment plan process? Do you have a credit card file and process in place, standards with your patients? Do you allow prompt pay discounts, based on the insurance company's contracts, whether you can do that or not? So I'm going to owe $4,000 in a high deductible starting in January as I consume healthcare. I may not be able to pay that right now. So what can you do with me, right? How can you help me? I still want to pay you, but can you work with me on that, right? So make sure you have flexible ways, credit financing, flexible ways in which you can solicit the payment from your patients to want to pay. And for those that don't, you really need to look at that patient population. Free care is not okay anymore. And I know in the elective surgical space, it's hard. In the smaller towns, it's hard. I hear a lot of times, well, I go to church on Sundays and things. And while I respect that and I understand that, they're going to be way worse off if you have to go out of business because you can't make payroll and you can't run a clinic. So the people need to be held accountable for the money that they owe. You need to be flexible, in my opinion, on how you get it. So overcoming the challenges, look, my biggest piece of advice for anybody out there who's trying to either consult on a rev cycle, run an RCM company, is if you don't have intelligence at your fingertips, which is not the same thing as data, it's not the same thing as dashboards, it's not the same thing as key performance indicators, right? It's really intelligence that tells you a story quickly on where you need to focus, or if things are where they need to be, then move on with all the other craziness in your day, right? I'm sure there's enough. I can speak for myself, there's plenty. The other piece is making sure that you put structure around the work that all of your folks do and make sure there's automation in that. And by automation, I mean carving out the things that don't need to be done today or don't need to be done at all, leaving the things that do need to be done to require work. And the last thing is, how do you measure the effectiveness of the work that you're doing? And that's really, how I would leave it. As I've said multiple times throughout this presentation, right? Labor cost reduction, improved net revenue. Those are the two things I hear consistently after consistent basis. Nowadays, more than ever, especially in the last 6 months. And I think that's a lot of that's coming out of this craziness with COVID and how that's impacted our ability to staff, and it's impacted the fluctuations to revenue. And I don't see that changing, at least in the short term. And so, we are here to help and consult in any form or fashion. So that's really it. 48 minutes. Sorry, Ashley. Thought I could do it in 43 minutes, but I don't know if there's questions that folks have. If you have some questions, pop them into the little chat here, I guess. And if you don't have a question and you think of one down the road, you could certainly reach out to us, and we will answer that. So, but we'll pause for a little bit and see if there's any questions.
Yeah, so I do have a few here, but yes, of course, please send your questions in the question area of the control panel. So on task management, are tasks stored at the claim level?
Yeah, that's a good question. So yes, in our system as it stands today, it is actually. So if I'm working a visit, or a claim, any tasks that I send out to other people will always be tied to that. And what's nice about that is that anytime someone goes and audits a claim, you can see all of the things that have gone on to try to get this thing paid, right? Whether it's an instant message or it was a task, or it's your AR representative working the claim. So that's a good question. Now, the second side of that, and this came up the other day, is what about creating a task that's not tied? Now, I'm not saying, you know, Dr. So-and-so likes Jamba Juice for lunch, so make sure we get that for the board meeting, you know, although I guess that would be helpful, or pick up laundry at 5. I usually just use my phone and try to remind myself to eat, pick up laundry, etc. But what if there are things that aren't tied to a visit that you do want to track, right? And so how do you do that today, you know? And so that's something that we're exploring here at medlevolve. The other thing I'll say too that we're exploring is a much more mobile way to communicate, and a lot of this is around our clinical staff, right? How could I engage in 1 or 2 clicks with a doctor? If I have a question for a doctor on medical necessity and I just need a quick clarification, he or she may not want to log in and answer a task, but would they click a yes or no or a quick comment on their phone? Maybe, maybe not. So we're starting to look at ways in which we can get mobile communication going on too. Remember, y'all, the outcome is still the same, right? I want to be able to be as efficient at getting you paid on time what you expect, and when that doesn't happen, be able to tell you why, and I want to do all that with as few people as possible.
Good. So another one is, can you create work lists based on denial codes?
So you should be able to, with the right system, you should be able to create a work list out of any structured data point that is stored in your data warehouse. If you don't have a data warehouse, it would be what's stored in your PM or coming back from your clearinghouse. So you should be able to create work ANSI denial code. You should have a ways to roll those ANSI codes up to categories or classifications. So Bob is responsible for no auth denials for Blue Cross, then it's 2 clicks of a button and that's what he's working, right? Claim status is important too, right? If the claim is in process, the claim is acknowledged, or the claim is paid, you don't want that stuff going to work list until enough time has gone by that should have resolved itself. So like in our world, claim in process doesn't hit until day 14 after that message was sent back from the payer. And at day 14, if that thing hasn't been paid and posted, then I do want someone calling, right? So payers, providers, financial locations, all of that is good structured data in which you can generate workflows.
Great. And then one person was asking, we're interested in providing incentives. How do you structure your incentive program?
Yeah, great question. So when we first started this journey a couple of years ago, we put in a broad-based revenue cycle incentive program. And so it was really everybody would be included in the payout. And there was 3 tiers, right? There was based on how they were hitting their budget with forecasted cash collections based on the tier that they exceeded by. They could get, you know, in some cases anywhere from $100 to over $500 per FTE per month, which for somebody making 18 to 22 bucks an hour, that's accretive. Now what we've started to do, because we can get into such a micro ability to look at each person as an individual, is we're starting to tie bonuses back to individual performance. And so the team is important, but I don't want to incentivize the entire team if 25% of the team is driving the results and the other 75% are not, right? And so now you're getting into another level of accountability. But in order to do that level, you have to have ways to measure the effectiveness of your people, okay? And so we're spending a ton of time in my data science department thinking through the algorithms that help tell a better story about a representative. And in our world, it gets a little more complex because I may see somebody who's having poor performance, but the clients that they're working on are very manual clients, as in the client needs to shape up, right? And so you have to think of all the variables that are out there that could impact the ability for someone to be as efficient as you want to be, and then build that into your model. So definitely encourage incentive-based revenue cycle. The first algorithm I came up with was in 2003. I was working in the large academic medical space, and I was amazed that, you know, if you had just given back a fraction of a penny in net revenue improvement to your employees, what that would do in terms of your overall P&L improvement was material. Yet nobody had the ability to measure the things that need to be measured to say whether somebody did a good job or not. Nowadays, you do. And if you don't, you've got to look at your software you're using.
Great. And then if anybody else has any questions, feel free to ask them. There was another question. They were all kind of different, but how would I get started with a data warehouse?
Well, go out to Amazon, search for data warehouse, buy one, and we'll be here by this afternoon. No, in all seriousness, the first thing you want to do is you actually, well, one, understand whether your current IT department, depending how large you are, has the ability to actually do that, or look for a partner that could do that, build it for you, right? So in our scenario, for example, we end up building the data warehouse off of our PM data, plus lots of other data points coming from our other vendors. So the first thing is, can you do it in-house? Yes or no? If not, where can you have it started? The second thing is, what data do you want in there and what do you want prioritized? So in our world, okay, I'm bringing in our practice management data. At times I could bring in EMR data. I'm bringing in all of my call center ACD data. I'm bringing in any appointment reminder data. I'm bringing in partner data. I'm bringing in lots of data from disparate sources, and then my team is normalizing that into a centralized data warehouse, and then we're overlaying workflow and we're overlaying analytics on top of it. So prioritization of what you want to bring in, which is really good to do the why I want to bring it in, what outcome I'm looking for, would be the second phase. And again, I go back to the data being hostage. If you're being told no, or it's expensive to get access to your data, you've got to look at the partnership you have with your vendors. Because all these vendors out there, look, they're collecting structured data, but if you can't grab it and work with it on your own time, what good is it? Right? It's very challenging to be valuable, build intelligence quickly when you don't have the control to work with the data yourself. Like I said, most of the PM vendors that I run into, probably all of them, are not building intelligence out of the PM, right? They may have reporting, they may even have a really cool dashboard, but it's not intelligence. There's a big difference between the two. And I don't have time to get into that, but if anyone wants to talk about that later, feel free to give me a call. Good questions.
All right, I think that's all we have for today then.
All right. Well, as always, we love doing these things. I told Ashley we're committed to doing more of these, so we'll come up with new topics of relevance. And at any point, if there's more discussion that you want, reach out to us, and we'd love to learn more about you and what you're up against. All right, that helps us kind of drive our roadmap too. So thanks for the time, and thanks for listening to me.
Thanks everyone. Thanks, Matt.